Thank you, ma'am and sir, for the kind introduction, and thank you very much, Pune Oncology Group, for this invitation. I've been really enjoying the sessions since morning, and I'm going to share over the next half an hour a few simple cases which we have encountered in uropathology, which we have struggled with, and hopefully my mistakes and my difficulties will help people in the audience. So this is a review we did, my colleague Dr. Devdeep actually did, which showed a major discordance of nearly 13% in the reviews we do in uropathology. And major discordance means the patient's management can change drastically. It's not just a different type of cancer or a different grade which will not affect management. These are treatment management. So that's significant to have a 13% discordance. The main issues where we struggle is the tumor classifications and staging for kidney, which changes management. Lot of inter-observer discordance in grading and assessment of muscle invasion. And in prostate cancers, the usual bane is the Gleason scoring. So with that overview, this is case 1, a 78-year-old male who presented with a PSA of 23, and TURP chips was reported outside from a very good lab as 3+5, and blocks were submitted for review. So we saw this in this magnification also. You can make out there are these small glands which are proliferated and the typical benign looking areas intermixed. Scanner view, and this is a low power view where packed small glands are seen. We can't really make out at this magnification whether they are bi-layered or single-layered, but seem to have an infiltrative look. Look at these glands over here. They're little angulated, irregular, and moving out from the well-circumscribed lobules which we see here. This is clearly benign, but these proliferations, back-to-back arrangement, and with these angulated glands moving out into the stroma. And on higher magnification, they do somewhat look single-layered. This is the high power view. I don't know if you can appreciate with this slide, but some of them are nucleolated. Definitely the nuclear size has increased. It's become pale, a little clumped chromatin, and some nucleoli are visible. Not very prominent, but they are visible. And then there were these glands with comedotype necrosis in them. Look single-layered, pale chromatin, small nucleoli visible in some of the cells, and comedotype necrosis. What would your Gleason score be? So there are rounded glands, no back-to-back arrangement, no cribriforming, and some glands with comedonecrosis. So we did this IHC. In most of the clusters, the typical lobulated one, P63, was maintained, but in the small angulated infiltrative ones, there was loss of P63. So if you, I should have asked for the diagnosis, if you go back and look at this slide properly, you'll see even these benign glands don't show P63 lining. So IHC can play tricks with you, and the most suspicious area that we saw here, this focus was lost in deeper cuts. So we could not do further IHCs, we could not do other basal markers like HMWCK to confirm the loss of P63, which we saw focally in these areas. So there was a difference of opinion. We showed this case around. The case, if you go back to the comedonecrosis area, you can see typical benign glands also have these histiocytes and infiltration. So this was in a background of prostatitis. In a background of prostatitis, the PSA can be increased. So don't look at the PSA when you're evaluating your prostate biopsy. It can mislead you, and especially when you have a known diagnosis coming from a good lab, you tend to be complacent, you tend to doubt yourself because some other pathologists had called it Gleason pat of 3+5. 3+5 is a high-grade cancer. The management is very different from a 3+3 or a benign. So some of us felt it was 3+3 based on morphology. In this case, IHC we could not base on because of these caveats, because of the processing artifacts. Some of the benign glands had retained basal cells, but some of the clearly benign glands also did not show P63, and the most suspicious foci was lost in deeper cuts. So on the basis of morphology, we called it atypical small acinar change in the background of prostatitis. After the TURP, the PSA level was followed up and it actually dropped to 0.06, and we got the MRI review. That was also PIRADS 4 and not PIRADS 5. So in the presence of adenosis, they can have a pseudo-infiltrative growth pattern. They can lose or have patchy staining for P63 and HNW-CK. So be very careful before calling a small focus adenocarcinoma, and most importantly, a focal 3+3, if you call this case, it's not going to make any difference. Patient will still get a follow-up kind of a management. But if you call this 3+5 by overcalling the necrosis and comedo type of necrosis, there can be a wrong management of this patient. ERG IHC can help to differentiate adenosis from adenocarcinoma, but because our suspicious foci were lost on deeper, we did not do ERG for this case, and we based our diagnosis on morphology. The second case is also similar, a 59-year-old male with an increasing PSA trend. Increasing PSA trend is very suspicious for malignancy, and we see this core biopsy with atrophic cell glands like this. We don't see a bilayered pattern, single irregular angulated glands. In high power, nuclear morphology shows prominent nucleoli, as you can see here. Some atypia in the nuclei. There was similar foci in other cores, and the P63 IHC was lost. So, and this is the HMWCK, strong diffuse positive in the basal cells. So in the setting of atrophy, be very sure to use 2 IHCs before you call something adenocarcinoma just on 1 IHC. So it is a AMACAR we have almost stopped doing, because AMACAR seems to come non-specific positivity both in cancer and benign, and patchy positivity doesn't really help you. You have to see a clear difference between a positive in adenocarcinoma and a negative in benign glands to use an IHC. So AMACAR is we don't find it useful, but be very careful not to use a single basal marker in the setting of adenosis, in the setting of atrophy for prostate cancers, because it may lead to an overcall of cancer. So always 2 markers, and 2 markers also give you 2 levels on biopsy. The experts in prostate do not advocate using IHC a lot, but they do multiple levels. In the West, evaluating 3 levels is compulsory, but in our center we have to take into account cost and all that. So do 2 IHCs if you have a suspicious foci. The third case was a 16-7-year-old male with hematuria and rising PSA. It was quite high. The PSA was 46 to start with, and then it increased to 78, and this is the core biopsy. Very busy slide, proliferated glands, multi-layered, some cribriforming. Even at this power we can appreciate. High NC ratio, cribriform. Atypical nuclei, prominent nucleoli, and this is the IHC with P63 well maintained in the basal level. So what would your grade be for this case? Anybody? Would you call it PIN, or would you call it intraductal carcinoma, or would you call it adenocarcinoma? And in this focus we see some small glands which have lost P63. So we had a choice between calling it adenocarcinoma 4+3, ignoring the IHC, or ignoring the intraductal component, or we can call it 3+4. We can call it prostate cancer 4+3 if we take these cribriform things to be intraductal carcinoma, which we include in the grade. And if we don't include that in the grade, we will call it focal involvement by 3+4 Gleason pattern. So grade group 3 versus grade group 2 changes management. And this is the confusion that the ISOP, the International Society for Urological Pathology, and the Genito-Urological Pathology Society, they provide the guidelines for our reporting. And there is a big difference of opinion between the 2 groups, and that confuses both us pathologists and the treating clinicians, because management can change drastically between the 2 grade groups. So this is a nice review by Dr. Verma and Dr. Epstein, who have done a comparison. Should introductory component of invasive prostate cancer be graded? Should you take them as grade 4, or should you take them as in situ carcinoma, which is not to be graded? This patient, this particular patient, we followed ISUP. We grade intraductal carcinoma. We don't use IHC in a frank malignant case like this. We restrict use of basal cell markers only to the cases which are doubtful for adenocarcinoma. When we are seeing adenocarcinoma, we report on morphology. The intraductal carcinoma component we include as a grade group 4. And as seen in this patient, the patient had a large volume T4 malignancy on radiology. So even if we called it 3+4, he would not have been stratified into intermediate risk, but treated as high-grade cancer. So for us who report oncopathology, it's not important just to know pathology, just to know morphology. We also need to know what are the guidelines, which aspects of our report actually affect patient's management, so that we can focus on focus on those categories rather than listing. If you see a prostate report, if you follow Epstein, who's the big leader in uropathology, a prostate cancer core biopsy, TURP biopsy report will run into 3-4 pages. And not all of us are equipped with labs which can give us time to report these prostate cancers for 2 hours, or do that many cores, levels and IHCs on every core. There are like 12 cores, 3 levels on each, which is the international recommendation, and then report on percentage pattern 4. I'm sure all of you follow the CAP, College of American Pathology guidelines. So the guidelines are exhaustive, but we have to know in our Indian setting what is applicable for our patients and what is not applicable for our patients, and give importance on those. So in the first 2 examples that I showed, if you did cost cutting and did not do the 2 basal markers, you would have made a error in diagnosis, and a patient with a benign disease would have gotten treatment, sometimes treatment for life. Like in the high-grade prostate cancers, they are on androgen deprivation therapy for life. And the low-risk ones, the Gleason pattern 3, they get radical prostatectomy or radiotherapy. So, so there is a difference of treatment between grade group 1 and Gleason group 1 and Gleason group 2. So keeping that in mind, whether you're calling somebody a focal 3+4 or a 4+3, depending on which guidelines you're following, GUPS or ISUP, it makes a difference. It's so important that you and your clinician have a clear dialogue. Whichever you're following, there is a lot of difference in opinion. I'm not an expert to actually comment on which is ideal, but we follow ISUP because we feel that is more pragmatic in the Indian setting. And the Gleason score is the most important. Next important is the percentage of core reporting. Again, if you see CAP protocol, they have different guidelines that should you report on each core, or should you give an overall grade for the entire specimen of 12 cores. So the ISUP recommendation is kind of that the pathologist should take the onus of, apart from reporting Gleason score on each core, they should give an overall idea to the clinician that is this a high volume tumor, is more than 50% involved or not. Give a global approximation, because sometimes you can have a 1 millimeter fragmented core which is 100% involved, and sometimes you can have a 10 millimeter core which is 1 millimeter involved. We all know that. So that impression your clinician who's not seeing the slide cannot make. So you are the best judge. We tend to indicate in our MDTs this to the patient. And percentage of pattern 4 is only important in radical prostatectomy patients. Otherwise, it is a prognostic marker. It's good if you can do all of this in your report, but currently for management, it's not really used. Case 4 is a 75-year-old patient with hematuria and TURBT. The blocks came to us for review with a diagnosis of high-grade urothelial carcinoma. This is, at this power, you can make out a tumor with papillary and glandular architecture. More glandular in this high power view. So adenocarcinoma has to be considered apart from undifferentiated or a urothelial carcinoma with glandular component. We didn't see too many solid areas, very high-grade tumor. And this was the GATA3 IHC. Diagnosis, anyone? GATA3 negative. And PSA strong positive. So this was a prostatic ductal adenocarcinoma involving the bladder. Actually, the bladder, the verumontanum region is a more common presentation site for prostatic ductal carcinomas. But you have to be aware, even in your prostate biopsies, they can be there in association with prostatic acinar carcinomas. They're important to report because the clinician gets an idea that androgen deprivation therapy does not work very well for these ductal carcinomas as opposed to acinar carcinomas. So this is important to keep in mind both for prostate and for bladder biopsies. We tend to forget about them and not do a PSA. For lack of time, I'm not going to be discussing our bladder cases in this talk, but actually bladder is the most common site of discrepancy in our practice, and the common issues are, I'm sure all of you have been facing, the difference of opinion on grade. So focal high grade area we see is often missed, and the pointers to not missing that is looking for mitosis and apoptotic bodies. If you see apoptotic bodies, you have to have a, your antenna should go up that I should not be missing high grade, and then go on to high power view to screen properly for mitosis. So focal high grade, MSKCC actually follows even a 1% high grade area. They call, their threshold for calling high grade urothelial carcinoma is very low. We use the WHO guidelines, which is more than 5% area has to be there to call high grade. And the second area of discrepancy is muscularis propria invasion and the inverted growth pattern. So the guidelines in the Western countries is calling a non-invasive tumor or an inverted growth pattern, you should get a 2 people dual sign out or 2 people to verify before you call that, especially for the high-grade urothelial carcinomas. And I wanted to share this, that Desmin IHC, we found it quite useful. Earlier, there is no good IHC which differentiates lamina propria muscle from muscularis propria. Smoothulin was talked about, but it doesn't really help. But we tend to use Desmin in our practice because we get a lot of cauterized biopsies, which look pink. And on screening, we tend to think that there is no tumor, there is no muscle there. We can't see the fragments. But when you use Desmin and then go back to the section, it helps to assess muscle invasion for 2RBT biopsies. Now moving on to kidney, this is my case 5, a 51-year-old female patient presenting with an exophytic renal mass. We generally don't biopsy our kidney tumors, but this was looking odd on radiology, so it was biopsied. And you can see this is the kidney parenchyma, and there's a glandular papillary kind of a tumor over here, and quite high grade. Clearly not non-clear cell. So at the outset, kidney tumor classification is changing every day, and as Jay showed one, so it is all molecularly based, almost getting very difficult to categorize kidney specimens and be abreast with all the subtypes there are, and most of us need access to a very high-end molecular lab to make those diagnoses. But at the outset, we should at least be able to say clear cell or not clear cell, and this was a non-clear cell papillary kind of RCC. So our differentials were, is it a papillary RCC type 2? Of course, type 1, type 2 doesn't need to be differentiated now. And or a papillary urothelial carcinoma of the upper urinary tract. These were our differentials. But on closer inspection, quite a few of the cells had these internuclear inclusions. Like you saw a case this morning by Dr. Santosh Menon, PAX8 positive, TTF1 positive, thyroglobulin positive. So for our PAX8 positive tumors, even if they are in the kidney, and very commonly you get these metastatic biopsies. The kidney, suspected kidney primaries are actually biopsied in the metastatic setting. Primary setting, they rarely biopsy unless the radiology is off. So whenever you get a PAX8 tumor, be very careful to, before you jump and call it kidney primary, do a thyroglobulin to confirm that it's not thyroid. So this was isolated metastasis to the kidney from a papillary thyroid carcinoma, again unknown primary, and we have seen that in quite a few cases where the thyroid does not show up and it presents with mets. Case 6, 40-year-old male patient presenting with back pain, right kidney, actually patient had a right kidney solid mass and a left renal cyst. And this is the radiology. And a very oncocytic looking tumor at this power. The cells are more or less bland, round to oval. Some of them have clearing. Almost like a mosaic pattern of eosinophilic cells and some clear cells. No good resinoid nuclei of chromophobe carcinoma was not very obvious, mostly round, bland, but some cells had atypia like this. The perinuclear clearing was also not obvious. We saw an occasional mitotic figure, but this was an odd one. Mostly there were no mitosis. CK7 negative. CD117, some vague focal staining, mostly negative. CD10 negative, GATA3 negative. Diagnosis. So this case I'm sharing actually as a tribute to Dr. Hess, who's done the most work on renal oncocytic tumors, and they have recently come up with this category of so our differentials here are oncocytoma, chromophobe, RCC. We did not see, there were some features of oncocytoma, and yet there was some atypia, some clearing, but not the typical features of chromophobe RCC. These hybrid tumors were earlier called hybrid oncocytoma chromophobe-like tumors. Nowadays, that has been reclassified into the hybrid oncocytic tumor in the setting of bilateral tumors or hereditary setting like Birt-Hogg-Dubé syndrome. And if it's a sporadic case, these have been reclassified as oncocytic renal neoplasm of low malignant potential, not further classified. There are these two other entities of oncocytic tumors, eosinophilic vacuolated tumor and low-grade oncocytic tumors. So the panel of IHC which helps, it's a combination of the morphology and the IHC of CD117, CK7, GATA3, which helps to categorize these tumors. And though all of them in this spectrum behave very well, even this eosinophilic vacuolated tumor, which was earlier known as the high-grade oncocytic tumor as opposed to low-grade oncocytic tumor, it is important to categorize these because chromophobe RCC also behaves very well, but for some you're stamping them as malignant, for some you're stamping as benign. So the follow-up is different, and the hereditary connotations, searching in the family, looking at the other kidney. So these follow-up and management connotations are different, and you never know how prognosis will change. For kidney tumors, it's an evolving thing, so don't stop your chase. And the thing to highlight this case, as I said, Dr. Hess really helped us out with diagnosing this, and he had unfortunately, he passed away this year. He's a doyen of renal urothelial pathology. So we call this tumor hybrid oncocytic in the background of renal oncocytosis, because 2 years later, this patient who had a renal cyst in the opposite kidney turned up with a second solid mass, and on resection, a similar low-grade, somewhat like oncocytoma, but with some features of atypia, and with this extension into the normal kidney, which showed presence of oncocytosis. So this was a renal hybrid tumor in the setting of oncocytosis, renal oncocytosis. Now my last case is a 2-year-old male child with a 11 centimeter solid tumor, clinico-radiologically Wilms. So patient was given chemotherapy as per SIA protocol, which is what we follow in India. And the response to chemotherapy was poor. Patient was operated, and we had this necrotic, large, cystic solid tumor. And on microscopy, mostly it was stromal with some epithelial component. The epithelial component was papillary and glandular, and again you saw a case in the morning. So it was a little off from the typical Wilms. You see the typical epithelial component of Wilms is tubular, but this seemed to have a primitive, almost yolk sac-like, almost looking like a Schiller-Duval body here, morphology. So we still called it, because of the age and the setting, though the tumor did not respond to chemotherapy, it was called a residual Wilms tumor, stromal type, intermediate tumor risk, stage 3, due to, there was capsular rupture. The tumor was very large, and because of the cystic nature, while taking out, there was rupture in the, at surgery. So why I wanted to discuss this case, for shortage of time, I can't go into further details. But again, we tend to follow CAP protocols in our country, most of us, but CAP protocols are based out of the US, and there they follow the COG, College of American COG protocols for pediatric Wilms tumors, where they do not give chemotherapy. So their reporting protocols vary from SIOP, which is the European organization, and in India also we give chemotherapy before our surgery. So there is a difference in the type of reporting terminology we use based on whether we are following SIOP or Children's Oncology Group recommendation, and the stage is also slightly different. So we have to, when we are reporting Wilms, keep this in mind. For SIOP protocol, you have to, the risk stratification is following this table, and you will find the reference online. So that is a little variation from the College of American Pathology or COG recommendation, which is commonly followed, which we refer to, most of us. So, so as I said, there was something a little off about this case. Even though it was, we called it Wilms, it was bothering us. The WT1 was negative, which is, especially the epithelial component can be negative for blastema. Epithelial component can be negative for WT1. PAX8 was also negative, and CK showed very focal staining. And the SAL4-IHC, which is a germ cell marker, was strong diffuse positive. So we send the case for molecular profiling to Dr. Rita Alagio, and this turned out to be a DICER positive Wilms tumor. DICER is not very commonly reported. DICER is the new kid in the block for pediatric oncology. In Wilms, it's not very commonly reported, only about 0.5 to 4 to 1% are reported to be positive, and it has management implications, especially for this kid. We screened the patient, and she turned out to have lung cysts. The patient also has a sibling, so it will affect management in the sibling. We have sent the case for germline testing. So this, coming to the take-home points of the varied cases that I have shown, the spectrum of molecular identification of tumors and the classification is changing every day. So it is very difficult to keep abreast, but if you are aware of what is going to be the management for your patient, it is not so difficult to tackle. For prostates, focal, as I said before, focal 3+3 versus adenosis atrophy, be very careful. Get a second opinion for the urothelial carcinomas, which are looking like inverted pattern to you, before you call it an invasion into the lamina propria. Correlation with history and radiology should not be missed, even in the most straightforward cases. Always think about a metastasis before you confirm primary, and never stop reading. Thank you.